Hello, so today we are going to talk about chronic heart failure. General overview of what we are going to talk about is definition, what is heart failure in general, classification, etiology, clinical presentation of the patients, diagnosis and differential diagnosis, then pharmacological treatments and some complications of heart failure. So, what is heart failure? The global definition of heart failure is as follows. It's a clinical syndrome with symptoms or signs caused by structural and/or functional cardiac abnormality, which is corroborated by elevated NT-proBNP level and/or objective evidence of pulmonary or systemic congestion. Congestion or congestive heart failure, it means that there is symptoms of fluid overload like peripheral edema, pulmonary edema, jugular venous distension, or ascites. Chronic compensated heart failure basically means the presence of heart failure, but the patient has stable symptoms. And acute decompensated heart failure, it means the presence of acute heart failure due to decompensation of pre-existing disease and cardiomyopathy, which is the most common, or it can be other causes. Also, another terminology which is used mainly only for pathophysiology reasons, left-sided heart failure and right-sided heart failure, systolic dysfunction and diastolic dysfunction. Systolic dysfunction, of course, associated with contractility, function of the heart, and diastolic dysfunction associated with the filling of the heart. So, for classification which is used in clinical practice, basically we say heart failure with reduced ejection fraction, milder reduced ejection fraction, reduced ejection fraction, and new terminology which is used is improved ejection fraction. So, HFpEF or heart failure with preserved ejection fraction, the ejection fraction will be more or equal to 50%, and there will be evidence on echocardiography of increased left ventricular filling pressure. There will be normal or reduced and diastolic volume and reduced stroke volume. Mildly reduced ejection fraction is between 41 and 49%, and evidence of increased left ventricular filling pressures. For reduced ejection fraction, it will be decreased less than 40% and decreased stroke volume. For improved ejection fraction, the patient already had heart failure with reduced ejection fraction, but with follow-up examinations and measurements of ejection fraction, we find that it's more than 40%. Another classification which is used in clinical practice is NIHA classification, NIHA functional classification, and also in some countries we may use American Heart Association stages of heart failure. So for NIHA classification or New York Heart Association functional classification, we have 4 classes. The first class means that the patient has no limitations of physical activity and he can do ordinary physical activity without any symptoms of heart failure. The second class means the patient has slight limitations of physical activity, still of course comfortable at rest, and ordinary physical activity only give some slight symptoms. Class 3, it means that there is marked limitation of physical activity. The patient is comfortable basically only at rest, and he is unable to carry ordinary physical activity without any marked symptoms. For class 4, it means that the patient is unable to carry any physical activity without presence of symptoms, and basically also address the presence of symptoms of heart failure are observed. For the American Heart Association stages of heart failure, we have also 4 classes or 4 stages. A, B, C, and D. A, it means that the patient is at high risk for developing heart failure but without structural heart disease or symptoms. B, it means there is already a structural heart disease or pathology present but without any symptoms. Stage C, presence of structural heart disease with prior or current symptoms of heart failure, and stage D means refractory heart failure requiring specialized interventions. Now coming to the etiology or the causes of heart failure. So most commonly you'll find causes which are cardiovascular. We talk about ischemic heart disease like myocardial infarction or coronary artery disease, presence of hypertension, mainly for patients which have uncontrolled hypertension and it's for many years, which will lead to development of complications like hypertrophy and eventually heart failure. Presence of valvulopathies like aortic insufficiency or aortic stenosis, arrhythmias like ventricular arrhythmias or even supraventricular arrhythmias like atrial fibrillation, myocarditis, constrictive pericarditis, and cardiomyopathies. And basically, all types of cardiomyopathies can precipitate heart failure. Hypertrophic cardiomyopathy, hypertrophic like obstructive or non-obstructive, but mainly obstructive, is associated with heart failure. Dilated cardiomyopathy, periparsum cardiomyopathy, alcohol-induced cardiomyopathy, and arrhythmogenic cardiomyopathy. Endocrine and metabolic pathologies can lead to heart failure, like thyroid pathologies, thyrotoxicosis, kidney diseases, diabetes, and obesity. Pulmonary diseases like COPD, pulmonary arterial hypertension, and cor pulmonale. Toxic conditions like chemotherapy, radiation therapy also has been included in the guidelines of heart failure. Alcohol, smoking, cocaine, and methamphetamines, or other conditions like genetic condition, genetic cardiomyopathy, or some congenital heart pathology. Autoimmune diseases as well can precipitate heart failure, like systemic lupus erythematosus and giant cell arteritis. Now let's speak about the clinical presentation of the patients with heart failure. So here I divided them into left-sided heart failure symptoms and right-sided heart failure symptoms, but basically in clinical practice we see the symptoms are mixed, and basically patient is presenting with biventricular heart failure symptoms. So if we are going to talk about left-sided heart failure symptoms, first of all, left-sided heart failure, it leads to increase either in the pressure or the volume of the left ventricle. Increasing in the overload of the volume or increasing in the volume of the left ventricle can be associated, for example, with the backflow of blood into the left ventricle caused by aortic insufficiency or aortic regurgitation, or it can be due to increasing pressure, for example, due to LVOC obstruction, which can happen, for example, due to aortic stenosis. And due to this increase in the left ventricular pressure or volume, we will have backup of blood into the lungs, and this will increase the pulmonary capillary pressure and eventually will lead to a cardiogenic pulmonary edema. And in the presence of pulmonary edema, the patient will be presenting with these symptoms like orthopnea, dyspnea, paroxysmal nocturnal dyspnea. Also, in the left-sided heart failure, there will be increased pressure in the bronchial arteries. We can have, like the patients can have symptoms which are mimicking asthma, of bronchospasm and airway compression, like shortness of breath, coughing, and on physical examination, some wheezing. Rales also can be present due to presence of pulmonary edema, coolness and pallor of lower extremities due to hypoperfusion of blood. Laterally displaced apical beats can be seen as well, and S3 and S4 heart sounds on auscultation. For right-sided heart failure, uh, in right-sided heart failure also there will be increase in the pulmonary artery pressure, and also it will be decrease in the cardiac output of the right side. And also to mention that right-sided heart failure mainly is caused or a consequence of left-sided heart failure. Anyway, due to decrease in the cardiac output in the right side, there will be systemic venous congestion. And systemic venous congestion, it will lead to presence of peripheral edema and also progressive congestion of internal organs. And here we are talking about the liver, about the stomach, for example. So the patient will be presenting with congestive cardiomyopathy, but rarely, mostly the patient will be presenting with signs of hepatosplenomegaly, hepatic venous congestion, jaundice, and abdominal pain. Also, jugular venous distension can be present on examination, hepatojugular reflex, and Kussmaul sign, which is distension of jugular veins during inspiration. This is a picture presenting the symptoms of heart failure. You can pause to have a look at them again. Now let's move into diagnosis and differential diagnosis of heart failure. So basically for diagnosis we will start with general examination, blood analysis using CBC and basic metabolic panel. We can check for signs of inflammation like leukocytosis, increased reactive protein, for example if it's caused by myocarditis, let's just say. We have to check also for the liver and renal function tests, as we know that they are affected in heart failure. Thyroid function tests are important to check as well as a precipitation etiology. Troponins can be checked if we suspect the presence of ischemia, coronary ischemic disease like myocardial infarction. We have to check also NT-proBNP levels because they are very important and they are showing us the progression of heart failure, but we should also keep in mind other conditions which may increase their level. ECG is used, of course, to check the presence of arrhythmias. Chest X-ray, we can use it to check for presence of pulmonary edema, for example. Transthoracic echocardiography is the main, actually, diagnostic tool which is used to check for the cardiac systolic function, diastolic function, any signs of hypertrophy, signs of cardiomyopathy, the presence of fluid, pericardial effusion, for example, or also to check using echocardiography to check the lungs in case of the presence of pulmonary edema, like pleural effusion. Some other advanced studies that can be used are cardiac MRI, which is mainly used for checking the extent, for example, of fibrosis in cardiomyopathies. Scintigraphy can be used as well. Right heart catheterization can be used if we suspect the presence of pulmonary arterial hypertension, and in rare cases and very specific cases, we may use endomyocardial biopsy. For differential diagnosis, we have to keep in mind pulmonary pathologies as well, which may cause these symptoms like dyspnea, for example. We have to check also some other conditions which are severe, like pulmonary embolism. We keep in mind also the history of the patients. We check other causes of edema as well, like lymphedema, which is not associated with a cardiovascular pathology or heart failure. Now speaking about the treatments, so the treatment here that I'm going to discuss is from the recent guidelines of um, European Society of Cardiology. So for heart failure with a reduced ejection fraction, the first class of medications which are recommended are either use of one of these, ACE inhibitor or ARB or an ARNI. ARNI basically is a combination of sacubitril with valsartan. The thing is that usually we start the treatments with just ACE inhibitor or ARB, and if they are not tolerated or not enough, we move to an RNA. And uh, RNA medication cannot be used at the same time with ACE inhibitor and ARB, so it be used only after the discontinuation of an ACE inhibitor or the ARB, at least for 36 hours. And usually we start it with very low dose, and after that we check the response of the patient. But based on my clinical experience, it's very, very effective for patients with a reduced ejection fraction. Also, from the first class medication which is recommended are beta blockers. So mainly metoprolol succinase has been associated with very good effects on heart failure patients and decrease in the mortality and hospitalizations of heart failure patients. MRA or mineralocorticoid receptor antagonists like spironolactone and eplerenone are recommended as well. Dapagliflozin or empagliflozin, basically they are diabetes medications, but many clinical studies have shown that they are very, very effective for heart failure patients. Also, loop diuretics are recommended for fluid retention, like furosemide, or if it's available in your country, it depends, like toracimide or bumetanide, but mainly which is used is furosemide. For patients with heart failure and preserved ejection fraction, first class recommendations are dapagliflozin or empagliflozin, and they can be used with diuretics. And it's recommended also the usage of statins, like rosuvastatin or atorvastatin in patients with high risk of cardiovascular disease or with coronary artery disease, basically to delay the progression and worsening of heart failure. Of course, with treating comorbidities and treating non-cardiovascular diseases, which may worsen the patient's clinical condition. Complications of heart failure are so many, but basically, the patients can have acute decompensated heart failure and cardiogenic shock in end stages of heart failure. Presence of cardiorenal syndrome and affection of the kidneys, chronic kidney disease, and also affection of the liver causing cardiac cirrhosis are also common complications. Presence of cardiac arrhythmias, also with its complications like stroke, pulmonary embolism. And that's all for this lecture. I hope it was useful, and thank you for watching.